Hello friends, today we are going to discuss about therapeutic plasma exchange in liver failure. So therapeutic apheresis is the oldest extracorporeal blood purification technique. Apheresis in Greek means to remove and includes removal of either plasma or blood cells. So therapeutic plasma exchange indicates extracorporeal removal of plasma in exchange for replacement fluid. So, the first application of therapeutic plasma exchange in hepatology dates back to 1990 when Dr. Teichspruss conceptualized high volume plasmapheresis, exchanging the entire extracorpuscular volume for 3 consecutive days with bilirubin clearance as a marker. So, therapeutic plasma exchange has been increasingly applied in hepatology. Among the various artificial liver support systems available today, only therapeutic plasma exchange improves survival in acute liver failure patients with encouraging data on survival benefits. So this figure is indicative of the various extracorporeal liver system which are used in the acute liver failure, which is divided into artificial and bioartificial. Artificial is divided into albumin dialysis, hemodialysis, and therapeutic apheresis. Albumin dialysis is again divided into molecular absorbent reticulating system, Prometheus, and single pass albumin dialysis. Therapeutic apheresis is divided into semi-selective, selective, and non-selective. Semi-selective includes double filtration plasmapheresis. Selective includes immunoabsorption. Non-selective includes therapeutic plasma exchange, which is again divided into centrifugal and membrane. So indications, the rationale for therapeutic plasma exchange in liver failure. So, what happens in acute liver failure? There is massive hepatocellular necrosis, which leads to the exaggerated systemic inflammatory syndrome triggered by release of damage associated molecular pattern and pathogen associated molecular pattern in the systemic circulation. The immune dysregulation and gut dysbiosis causes endogenous intoxication syndrome that lead to infection and multi-organ failure. Also, an impaired ability to synthesize urea leads to the hyperammonemia and encephalopathy, which in severe cases leads to cerebral edema and intracranial hypertension. Therapeutic plasma exchange non-selectively purifies blood toxin of various sizes, distribution volume, lipophilicity, and protein binding. It replaces the coagulation factor complement lipoprotein with fresh frozen plasma. Therapeutic plasma exchange also reduces the DAM's gut-derived endotoxin, pro-inflammatory cytokine, adhesion molecule, vasoplegic mediators, and toxin metabolites such as ammonia, aromatic amino acid, creatinine, lactate, bilirubin accumulated in the plasma. So the ammonia lowering effect of the plaques elevates the encephalopathy and cerebral. So plaques improve survival by removing macromolecules which are too big to dilate, such as 1 Wilbrand factor multimers, which is more than 10,000 kilodalton, that can clog the liver sinusoid and impair the hepatic microcirculation. Therapeutic plasma exchange also supplements proteolytic enzyme Adams 13 through fresh frozen plasma, which helps 1 Wilbrand factor cleavage and restores the hepatic microcirculation. High volume plasma exchange improves systemic hemodynamic by improving endothelial function, systemic vascular resistance, arterial blood pressure, and hyperdynamic circulation. So therapeutic plasma exchange also has immunomodulatory effect on innate immune system, and it also restores monocytes and neutrophil functionality. So, if I want to summarize, therapeutic plasma exchange secures liver's metabolic, excretory, and synthetic function and modulates early innate immunity, thus serving as an ideal liver assist device in acute liver failure. Thus, the early application in hyperacute stage of ALF limits the pro-inflammatory storm and subsequent anti-inflammatory response. So, these are the indication of therapeutic plasma exchange in hepatology. Like we can use therapeutic plasma exchange in fulminant Wilson's disease, acute liver failure, acute and chronic liver failure, refractory cholestatic pruritus, acute decompensation of cirrhosis, post hepatectomy liver failure, and severe alcoholic hepatitis. And in transplant etiology like ABO incompatible liver transplantation, early allograft dysfunction, chronic rejection, primary non-function, and antibody mediated rejection. The organization of therapeutic plasma exchange services and machines. Therapeutic plasma exchange can be administered via centrifugal and membrane filtration. Apheresis units based on the transfusion medicine and hematology perform centrifugal therapeutic plasma exchange. So, liver intensivists and nephrologists, they are performing membrane therapeutic plasma exchange, while multifunctional renal replacement therapy machines. Now, what about centrifugal therapeutic plasma exchange? In centrifugal therapeutic plasma exchange, whole blood is spun in centrifugal fashion, separating the blood component around the axis of rotation in order of increasing specific gravity. So the plasma in the innermost layer is separated while remaining blood element return to the patient mixed with an equal amount of replacement fluid. So therapeutic plasma exchange machine have plasma removal efficiency of 80%, allowing more considerable removal in shorter session. The additional advantages include ability to perform blood transfusion, leukocyte reduction, and the avoidance of systemic anticoagulation with heparin. The acceptable pre-procedural hematocrit in adult is not well defined. However, an hematocrit of more than 22% or hemoglobin of 8 mg or less than 10 to 15% of blood volume in extracorporeal circuit is recommended, failing which the circuit priming with blood transfusion may be required. Now about membrane therapeutic plasma exchange. Membrane filtration is conceptually similar to isolated ultrafiltration in dialysis and relies on convective clearance. So plasma removal efficiency depend on membrane pore size, surface area, sewing coefficient, and plasma filtration rate. So membrane therapeutic plasma exchange separates the plasma protein from cellular component depending on particle size. Protein with molecular weight up to 500 kilodalton can selectively permeate the membrane with pore size of 0.2 to 0.6 mm. So the two membrane separation filtration filters like Plasma Flow OP and Plasma Flex Therapeutic Plasma Exchange series are compatible with RRT machine and have high sewing coefficient, which are allowing plasma identical filter. For high ultrafiltration rate, membrane therapeutic plasma exchange require higher blood flow and central venous access. So as hematocrit increase, serum protein get absorbed in the membrane, increasing transmembrane pressure and decreasing solvent flux. A TPM of 50 mmHg risks the filter clogging and therapy discontinuation. So the strategies to counter increase therapeutic transmembrane pressure include systemic heparin, anticoagulation, targeting filtration fraction to 20% to 30%, and reducing blood flow rates. So altogether, plasma removal efficiency is limited to 30% to 35%. Hence, for 1.2 into plasma exchange, the patient's blood need to be processed 3 or 4 times. The higher blood flow rate in membrane therapeutic plasma exchange may lead to hemodynamic fluxes, adversely affecting the hepatic microcirculation. Also, membrane filtration may activate the blood cells, exacerbating liver's inflammatory milieu and causing hemolysis. Platelet loss is commonly observed in patients undergoing centrifugal therapeutic plasma exchange, although platelet loss can also occur from membrane activation and sequestration during membrane therapeutic plasma exchange. So this diagram is representative of centrifugal therapeutic plasma exchange and membrane therapeutic plasma exchange. So as you can see in the diagram, centrifugal therapeutic plasma exchange is conducted by the apheresis machine, and the main principle behind it is centrifugation. while the membrane therapeutic plasma exchange utilizes membrane filter for separation, and the principle behind this is convection. So this is the difference between centrifugal and membrane therapeutic plasma exchange. Very, it's very important. So we have to memorize it. So let's see what is centrifugal therapeutic plasma exchange. As I have mentioned before, it is conducted in the apheresis machine. It has a plasma removal efficiency of 80%. Blood flow rate is lower, that is 10 to 150 ml per minute. Procedure time is more. Anticoagulation that we are using here is citrate, and it can perform cytopheresis. There are chances of more thrombocytopenia, and they may need blood prime. Regarding membrane therapeutic plasma exchange, it requires dialysis or CRRT machine. Plasma removal efficiency is 30%. Blood flow rate is higher than the centrifugal, that is 150 to 200 ml. Procedure time is less. Anticoagulation is citrate. We can use heparin. It can perform dialysis, may can lead to hemolysis, and there is a risk of filter clogging. Now, the basic principles and terminologies which are used in therapeutic plasma exchange. So, there is a formula to calculate effective plasma volume. Now, how to calculate it? So, if you go by formula, the formula is body weight into 0.065 into 1 minus hematocrit. A pathogenic substance, that is, if there is a patient's weight is 70 kg, and if the patient is of normal hematocrit, then the effective plasma volume is approximately 2.5 to 2.7. The pathogenic substance to be removed through therapeutic plasma exchange should ideally have higher molecular weight, low protein binding capacity, higher intravascular distribution, low formation rate, and the prolonged half-life. There is a non-linear relationship exists between the volume exchange and the substance clearance. So according to the kinetic model, to reduce substances by 50%, 63%, 75%, or 95%, the effective plasma volume exchange should be around 0.7, 1, 1.4, and 3 times respectively. Thus, the absolute amount removed becomes progressively smaller with additional plasma volume exchange. Substances with the sizable extravascular distribution are removed more slowly depending upon their distribution to the intravascular compartment. Additionally, resynthesis can lead to post-therapeutic plasma exchange rebound. Hence, for net reduction, repeating therapeutic plasma exchange several times every 24 to 48 hours may be more efficacious than continuing high-volume therapeutic plasma exchange beyond 1 to 1.5 plasma volume. Plasma removal efficiency is the fraction of plasma removed per procedure by therapeutic plasma exchange device. However, the degree of substance removal is not equivalent to response. The transmembrane pressure is the pressure gradient driving the solute across the membrane. And the swing coefficient measures how effectively a molecule of particular size, protein binding, and charge is moved across the filter. Now about semi-selective technique. The cascade filtration and double filtration plasmapheresis. In double filtration plasmapheresis, a plasma separator separates the plasma from the blood cells, and the plasma component separator fractionates the large molecular weight immunoglobulin and cryoglobulin from the small molecular weight component like albumin and coagulation factor. In ABO incompatibility liver transplant, double filtration plasmapheresis with secondary filter of middle pore size is recommended as it maximizes selective removal of isoagglutins, minimizes albumin loss, and can handle large amount of plasma, that is 1.5 to 3 times of plasma volume, and it requires less replacement fluid. Now, the next is immunoabsorption. Immunoabsorption is the most selective extracorporeal technique for removing performed ABO isoagglutinin, especially for emergent ABO incompatible liver transplant and treating an acute antibody mediated rejection. So immune absorption technique with secondary device containing globafin twin absorber regenerative system utilizes synthetic ligand which has strong binding affinity for IgG constant section. The glycoside ABO column has been developed to remove anti-A and B antibody in ABO incompatible recipient. So treated plasma is then reinfused. Now about choice of vascular access. Choice of vascular access is determined by patient and the procedure related factor. So centrifugal therapeutic plasma exchange typically requires lower blood flow rate, that is 50 to 120 ml per minute, which is achieving through 70 to 17 to 19 gauge peripheral vein and central venous axis. There is recent shift worldwide from the peripheral to the central venous axis, as peripherally inserted catheter might collapse with negative pressure exerted during therapeutic plasma exchange, increasingly treatment time and decreasing efficacy. Comparatively, the membrane therapeutic plasma exchange devices requires higher blood flow rate of 150 to 200 ml per minute and requires 7 French standard triple lumen central venous and 11.5 French hemodialysis catheter, 13.5 French double lumen catheter. Central venous access is preferred in renal failure patient requiring sequential hemodialysis and therapeutic plasma exchange. CKD patient on hemodialysis needing therapeutic plasma exchange can access arteriovenous fistula. Catheter and procedure related complications include inadvertent arterial puncture, bleeding, pneumothorax, air embolism, central line associated bloodstream infection, catheter dysfunction, thrombophlebitis, and deep vein thrombosis. Now about choice of anticoagulation. Extracorporeal circuit clotting is the most frequent technical complication, and anticoagulation with systemic heparin and regional citrate aim to prevent blood clotting, thereby maintaining circuit potency. Regional citrate anticoagulation with ACD-A and the ACD-B is preferred anticoagulation for both centrifugal therapeutic plasma exchange and the membrane therapeutic plasma exchange. The risk of the citrate toxicity and the bleeding in centrifugal therapeutic plasma exchange is low because the discarded plasma remove 80% of citrate. However, with membrane therapeutic plasma exchange, higher blood flow rate and the lower this plasma removal efficiency increase the risk of citrate toxicity, especially in patients with impaired liver and kidney function. So citrate toxicity is common with high volume plasma exchange and FFP replacement, as each FFP contains approximately 7 mmol citrate, and metabolism of each citrate molecule generates sodium bicarbonate molecule manifesting as hypocalcemia, hypomagnesemia, and metabolic alkalosis. So, a safe monitoring approach includes determining the total to ionized serum calcium ratio before and after therapeutic plasma exchange session, supplementing prophylactic calcium during PLEX. So, liver failure patients have balanced but brittle coagulation system and systemic heparinization during therapeutic plasma exchange that can aggravate the bleeding risk by inhibiting factor 2A and 10A via antithrombin 3. On the contrary, 1.7% patient had extracorporeal circuit clotting in heparin-free group, suggesting heparin-free therapeutic plasma exchange regimen should be considered in liver failure patient. In patient receiving heparin drip should be discontinued 1 hour before, and therapeutic plasma exchange is done in standard fashion with citrate. So, warfarin and directly acting oral anticoagulant may be removed with therapeutic plasma exchange, and the coagulation factor may be added with FFP, leading to variable half-life. In complex situation, viscoelastic test can provide therapeutic guidance but remain to be evaluated. Now about choice of replacement fluid. Typically, single volume plasma exchange remove 30 to 40 ml per kg of plasma, and it requires replacement with equal or greater volume of replacement fluid, which is either FFP and albumin, depending upon therapeutic plasma exchange indication and bleeding risk. So the FFP is most commonly used in liver failure patient, as it lacks post-treatment coagulopathy and immunoglobulin depletion. In high volume plasma exchange, FFP volume required are higher, which increases the blood bank burden and cost and are associated with infectious disease transmission risk, anaphylactic reaction, transfusion associated circulatory overload, and transfusion related acute lung injury. In studies in ACLF patients which have combined FFP and albumin, considering that circulating albumin in ACLF patient could be dysfunctional. Hence, proportion is replaced with 2 liter of 4% human albumin, diluting 400 ml of 20% human albumin with 1600 ml NS. Repeated plasma exchange and replacement with albumin can be associated with loss of growth and coagulation factor. A study measured pre and post this TP fibrinogen level and found that levels significantly declined by 54% using 5% albumin and 30% with using combination of FFP and albumin. In patient coagulation profile before and after each therapeutic plasma exchange should be carefully monitored, and if fibrinogen levels are less than 150, FFP should be transferred. Although not recommended, clause-limited healthcare system and patients who refuse blood component, 80 to 20 albumin and NS combination should be used with minimum ratio of 70 to 30. Crystalloid should be administered at the beginning of therapeutic plasma exchange to avoid significant fluid shift from intravascular into extravascular space and to avoid hypotension. Now, practical application of therapeutic plasma exchange in hepatology. So, in ALF patient, therapeutic plasma exchange should be initiated immediately after onset of hepatic encephalopathy, irrespective of transplant prospect, either waiting on list or having contraindication for liver transplant, and liver transplant being unavailable. So, EASL recommended initiating high volume plasma exchange in less than 48 hours following ICU admission in ALF patient. It has been hypothesized that the later stages of ALS, the macrophages are primed to promote liver regeneration, which decreases its utility. Also, with immune paresis and multi-organ failure, high-volume plasma exchange may potentiate increased risk of sepsis due to non-selective removal of beneficial growth factor and antibiotics and antifungal. In ACLF patient, therapeutic plasma exchange should be initiated in golden window period to target sterile systemic inflammation, preventing multi-organ failure and infection, as evolution of ACLF status determines the prognosis. Therapeutic plasma exchange intensity. ALF has two strategies, that is continuous 3-day versus intermittent response guided therapeutic plasma exchange. Larson et al. Perform three therapeutic plasma session on 3 consecutive days, and survival was significantly better in those who received three plexus. So Larson's protocol was based on two facts. Mechanistically, 3 consecutive sessions of therapeutic plasma exchange reduces extracellular toxin concentration to 18% of the base. And Laren study exchanged about 23 liter per treated patient. So pragmatically, higher volume and more prolonged treatment period would strain the blood bank and might contribute to functional immunosuppression and increased sepsis. In donor scarce countries or liver or live donor liver transplant center, response guided approach wherein therapy is individualized and performed at various interval based on individual need and responses seems more plausible. About volume of plasma exchange. The clinicians have tried high standard and low volume therapeutic plasma exchange to treat ALF and standard or low volume therapeutic plasma exchange for ACL. A recent meta-analysis showed consistent survival benefit in ALF regardless of high volume plasma exchange or non-high volume plasma exchange, favoring therapeutic plasma exchange over this standard medical therapy. So, high volume plasma exchange refers to the exchange volume equivalent to 10 to 15% of ideal body weight or 8 to 12 liter or inconsistently as 2 to 3 times of effective plasma volume per procedure. So single volume plasma exchange refers to 1.5 to 2 times of plasma volume or 5 to 6 liters of plasma volume exchange per therapeutic plasma exchange. In ACLF patient, most reported literature favors single volume plasma exchange. Large volume plasma exchange refers to the 1.2 liter or zero point 0.5 into plasma volume exchange per therapeutic plasma exchange session. So large volume plasma exchange, it is an attractive option as it strains the blood bank and resources less and may be more affordable and is associated with reduce the risk of TRALI and blood-borne infection. So about monitoring discontinuity and futility criteria. The decision to continue therapeutic plasma exchange beyond 3 sessions should be individually assessed based on therapeutic plasma exchange efficacy and safety. So therapeutic plasma exchange alters most lab result, hence result must be interpreted cautiously. Most importantly, therapeutic plasma exchange artificially correct coagulation test and there be prognostically indices which challenges clinician to decide need for urgent listing in liver failure patient. A progressive improvement in clinical and lab parameters should suggest disease process improvement and the response, while worsening and rebounding or developing severe adverse effect suggests the non-response or futility. So it is sobering that many therapeutic plasma exchange non-responders die in the absence of liver transplant. Thus, it is essential to establish futility criteria. The proposed futility criteria for therapeutic plasma exchange are patient with brain herniation, ACLF patient with more than 3 extrahepatic organ failure and MELD score of more than 30, and patient with hemodynamic instability, active uncontrolled sepsis, recent GI bleed, and DS. Evolving data suggests that future therapeutic plasma exchange regimen could be personalized based on biomarkers. So the biomarkers like serum neopterin and soluble CD6 630 163 suggest macrophage activation in paracetamol-induced ALA and serum ferritin and plasma 1 Wildbrand factor level mark reticuloendothelial activation. Interleukin 1 receptor antagonist and anti-inflammatory cytokine could be a potential biomarker suggesting a response to therapeutic plasma exchange in ACLF patients. So the further research is required to identify biomarker with their specific cutoff that can predict the illness stage and trajectory and guide the timing of therapeutic plasma exchange. Now about combined circuit. Critically ill liver patient on therapeutic plasma exchange may need another extracorporeal therapy such as renal replacement therapy or extracorporeal membrane oxygenation. The options are to perform procedures simultaneously or sequentially. Excitingly, the combined procedure reduces total procedure time, avoid additional central line replacement, reduce overall anticoagulation. However, they are complex, require skilled team to mitigate potential associated complication and are off-label. So hybrid procedure combining therapeutic plasma exchange and continuous venovenous hemofiltration and hemodiafiltration are attractive from pathophysiological perspective in ALF patients. Liver failure with hyperammonemia alone requires TPE and CVVHF. In contrast, liver failure with AKI requires plasma exchange with CVVHDF to clear different size molecules simultaneously. CVVHF removes low molecular weight cytokine ammonia free water, which ensures high sodium level to counteract cerebral edema. CVVHDF utilizes principle of diffusion and convection to clear low and medium molecular weight solid. If both TP and CVVHDF are required in patient, therapeutic plasma exchange should be performed first because blood pH and the volume changes resulting from therapeutic plasma exchange can subsequently be corrected by dialysis. So therapeutic plasma exchange can be combined with plasma perfusion or plasma diafiltration in patient with ACLF to eliminate toxin with different molecular weight simultaneously. However, there is insufficient evidence to confirm its efficacy and the safety. So, in recent systematic view, therapeutic plasma exchange alone regimen showed more remarkable 30-day survival than combining therapeutic plasma exchange with other acute liver failure survival system and SMT. Now about safety and adverse effects. Although therapeutic plasma exchange is well tolerated and safe, critically ill liver patients are highly vulnerable due to coagulopathy and electrolyte disturbances and hemodynamic instability resulting from hypoalbuminemia, capillary leakage, and altered volume of distribution and organ failure. Hence, close monitoring by experienced ICU team is required. The adverse events are mainly related to apheresis device, vascular access, replacement fluid, and anticoagulation. Anaphylactic rash, hypotension, bleeding are the most reported ones. Potential life-threatening anaphylactic reaction can result from increased bradykinin level due to AC inhibitor intake, replacement with albumin dextran sulfate, which increases the prekallikrein activation factor concentration, usage of older hydrophilic and electronegative polyacrylonitrile membrane, ethylene oxide from membrane sterilization, and IgA transfusion through FFP in patients with selective IgA deficiency. Preventive measures include prophylactic administering antihistamine and glucocorticoid while using FFP and holding ACE 48 hours before therapeutic plasma exchange. Hypotension is commonly reported and potential mechanisms include delayed and inadequate volume replacement, more than 30% replacement with crystalloid, anaphylaxis, bradykinin reaction, bleeding from vascular access, vasovagal episode, trali, and arrhythmia. Hypotension is managed by reducing blood and circulating circuit flow speed or replacing 110% of volume exchange or low dose noradrenaline. Thank you, guys.